Hello, everyone, and welcome back to the third session of clinical pharmacology, clinical therapeutic of hematology. And the last session will be anticoagulant and and fibrinolytic agents. Again, I'm Dr. Khaled Hassan, professor of clinical pharmacology and clinical research. Okay, in this session, in this last session, we are going to speak about anticoagulant and fibrinolytic. So, as you can see here, with our topic about anticoagulant, the main medication, the most important medication, we have heparins, then we have oral anticoagulant, then we have warfarin. Okay, heparin bind to the antithrombin 3. We ask about what is the mechanism of action of heparin, how we monitor heparin therapy. Okay, unfractionated heparin, UFH, stand for the heparin, accelerate, enhance activity of antithrombin, AT3, antithrombin, enhance inactivation, accelerate. So what happened here? Heparin bind to the antithrombin, and this antithrombin 3 will inactivate factor 2A and 10A, and this present anticoagulant effect. How we monitor the heparin therapy? We monitor heparin by APTT, activated thromboblastin, partial thromboblastin time, APTT. Bleeding could be reversed by using protamine sulfate. Heparin associated with the risk of HIT, which stands for heparin-induced thrombocytopenia, which means decrease platelet activity or decrease platelet number. Okay, LMWH versus standard differences between two types of heparin, low molecular weight heparin versus unfractionated heparin. Here we talk about, for example, enoxaparin versus heparin differences. Enoxaparin, deltaparin, as you can see it here on the slide, low molecular weight heparin, LMWH. It's more anti-factor 10 specific, better bioavailability, long half-life, prescribed to the outpatient, less HIT, which stands for heparin-induced thrombocytopenia, monitoring often not needed. Here, a very important issue, both heparin and low molecular weight heparin should be avoid IM. IM meaning intramuscular. The statement here is not allowed to prescribe heparin, enoxaparin, deltaparin intramuscular to the patient. Don't inject these substances, three drugs intramuscular, because this is carry the risk of hematoma. Okay. Next medication will be Fondaparinux. We are speaking about action and the class here. Fondaparinux considered like synthetic bentasaccharide, indirectly selective anti-factor 10A via the antithrombin 3, and this medication prescribed subcutaneous once daily Fondaparinux. Okay, target factor 10A. So if you compare Fondaparinux with the low molecular weight heparin and heparin, with the heparin bind to the antithrombin 3 and inactivate factor 10A and 2A. Okay, we have medication, oral medication, new medication introduced to the market a few years ago. Factor 10A oral inhibitor, oral anticoagulant medication. Yes, as you can see here, we have Apixaban, Rivaroxaban, Endoxaban, Betrixaban, and we have Xaban. And if you like to remember this name here, we can maybe use some nomination for the situation here, for example. Okay, so as you can see, we have Xaban here. We have Xaban, we have factor 10, You see, Xaban, this is oral anticoagulant. That means prescribe it orally, selectively inhibit factor 10A. Yes, we have A here, as you can see. You have factor 10A. Okay, and this medication prescribed for the patients are from atrial fibrillation, stroke prevention, deep vein thrombosis, pulmonary edema, uh, even for treatment or prevention. This medication carry the risk of bleeding, and if the patients are from renal impairment function, renal disease, we need to adjust the dose for this medication. Again, we have Apixaban, Rivaroxaban. Okay, we have Apixaban, Rivaroxaban. Okay, and then we have Endoxaban. For more details, we can speak about the differences between these medication, Apixaban, Rivaroxaban, and Endoxaban, as oral selective factor 10A inhibitor. Okay, moving to the next group of medication. Here we talk about the direct thrombin inhibitor. Uh, it's like, are you going to speak about IV or oral medication? So here we have Dabigatran, oral direct thrombin inhibitor. Dabigatran, oral direct thrombin inhibitor, factor 2A. Then we move to the Argatroban. Argatroban prescribed IV, direct inhibitor of factor 2, and we use it for HIT. So this group of medication, Dabigatran and Argatroban, we use it for the patients from heparin-induced thrombocytopenia. Other option for HIT, we have bivalirudin, disoridine, also considered like IV medication for patients from heparin-induced thrombocytopenia. Warfarin, another important drug in the clinical practice, is talk about what is the mechanism of action and how we can monitor heparin treatment. Heparin, considered like vitamin K, um, oral medication, bind to the vitamin K oxidase enzyme, decrease activity of factors 2, 7, 9, and 10. Okay, warfarin considered like narrow therapeutic index. Warfarin carry the risk of interaction. We monitor warfarin by measuring INR, which stands for International Normalization Ratio. The INR normally should be between 2 to 3. Warfarin considered teratogenic. We don't prescribe it to the pregnant woman, contraindication during pregnancy. If the patients are from toxicity due to the overdose or like high level of warfarin, we can treat this patient with the antidote, which will be vitamin K. Heparin overdose management. Here, how we can treat patient with overdose of heparin. Okay, the first of things, we need to stop this medication. The antidote here will be protamine sulfate. Let's maybe repeat what we have done about the management of heparin overdose or like toxicity. First of all, we need to stop the medication. We need to stop heparin and consider prescribe protamine sulfate. We need to evaluate APTT, and we need to evaluate patient clinical status there. Warfarin, if we have toxicity or overdose or like high INR of warfarin, what is the action there? Minor bleeding, for example, like epistaxis, for example. How we can manage there? So when you have minor bleeding from the warfarin and INR like 4.2, the action will be hold the warfarin and give oral vitamin K. As you can see oral vitamin K bleeding. However, if the patient suffers from severe bleeding from like hemorrhage, stroke, stomach bleeding, we need to prescribe vitamin K IV, and with the addition of plasma, fresh plasma, or like a platelet concentration solution. Okay. HIT management here. HIT stands for heparin-induced thrombocytopenia. When the patient prescribe heparin, some of the patient may prescribe from heparin-induced thrombocytopenia, mean decreased number of platelet. How we can manage the situation? We need to stop using heparin, stop using low molecular weight heparin. We can start non-heparin anticoagulant, and the drug of choice here will be Argatroban. And this is a national exam question. If you have patients suffer from like a coagulation case and you prescribe heparin, however, the patient after 2 or 3 days starts suffering from heparin-induced thrombocytopenia, which the following medication considered like drug of choice for continued treatment with anticoagulant. So the correct answer will be Argatroban. Okay, last section for the clinical pharmacology and therapeutic of hematology. We talk about thrombolytic and antidotes here. Two medication. We have another one. It's like it's not very rare to be used now. Two medication belong to the thrombolytic. We have Alteplase and tenecteplase, and the primary uses for this two medication. So what are the primary uses of Alteplase and tenecteplase? We use it for acute STEMI when BCI unavailable, when you have massive pulmonary embolism, PE, acute ischemic stroke. We prescribe it this medication IV. This medication, how this medication work, mechanism of action. Here we talk about mechanism of action. This medication activate plasminogen to convert to plasmin, and this will dissolve fibrin. Which lab we use to monitor heparin or unfractionated heparin? Which lab test we use it? We use a PTT, activated partial thromboplastin time, and we have the target 1.5, 2.5, control per protocol. Dabigatran, they consider like reversal agents. We have another group of medication. Here we have, if the patient take Dabigatran and the patient suffer from overdose or bleeding, how we can treat the Dabigatran overdose or bleeding. The medication available in the clinical practice, adalimumab, and this is monoclonal antibody and antidote for the patients from emergency or like life-threatening bleeding due to the use of Dabigatran. So what is the antidote for Dabigatran? The antidote for Dabigatran will be adalimumab. Antidote summary, we look on the summary for the antidotes in general. Heparin, we have protamine sulfate. Warfarin, we have vitamin K. Fibrinolytic, we have aminocaproic acid, tranexamic acid. Okay, this will conclude our activity flashcard for clinical hematology, anemia, antiplatelet, and anticoagulant, in addition to the fibrinolytic agent. And we cover the antidote for some risk of bleeding or risk of like overdose. We talk about warfarin, heparin, Alteplase, tenecteplase, and so on. Thank you so much for watching, and have a great day.